Welcome to the deep dive. Today we're tackling a really intricate but vital area, developmental issues affecting the renal arteries, the plumbing to the kidneys and the main artery in the belly, the abdominal aorta, specifically in children.
Yeah, it's fascinating stuff.
We're drawing on the detailed information in Rutherford's vascular surgery and endovascular therapy to really understand these conditions.
And what's really key here is that even though these are complex conditions and frankly how they develop isn't perfectly understood,
Right.
the good news is that treatments have actually improved quite a bit. So our goal today really is to make sense of these disorders and how the right interventions, at the right time can be absolutely life-changing for carefully selected kids.
Okay, let's unpack this then. We should probably start with developmental abdominal aortic coarctation. Now, if you've heard about aortic coarctation, you might think chest area, but this is specifically the abdomen. This isn't like a brand new discovery, is it?
No, not at all. Actually, the first description goes way, way back to 1847 by a physician named Quain. For a long time, though, it was considered pretty rare. It was really the advances in aortic imaging, especially later in the 20th century, that let doctors recognize it more often. And that led to the term some people might know, Middle Aortic Syndrome, or MAS.
Middle aortic syndrome. Okay, that name really points to the location. So when doctors see this, how do they, classify it? Are there different types?
Yeah, there are. The classification basically depends on where the narrowing is highest up, sort of towards the head. Generally, there are three main types.
Okay.
The most common one, we see it in about 69% of cases, is suprarenal. That means the narrowing is above where the kidney arteries branch off.
Above the renals, right.
Exactly. Then there's interrenal, where the narrowing actually includes the section where the renal arteries start. That's about 23%.
Yeah.
And finally, infrarenal, least common, maybe 8%, where the narrowing's below the renal arteries. And it's important, to distinguish this sort of localized narrowing from a more general underdevelopment of the whole aorta, which we call diffuse aortic hypoplasia.
That's a key distinction. So what actually goes wrong during development to cause this coarctation? It's not like arteries getting clogged in adults, right?
Absolutely not, no. The main idea, the leading theory, points to something happening very early in fetal development. We're talking around the 4th week of gestation.
Wow, tiny.
It's called the overfusion theory of the two dorsal aortas. See, normally, a fetus starts with two aortas side by side.
Two. Okay.
Yeah, and as development progresses, they're supposed to fuse into the single aorta we have after birth. And during this whole fusion process, all these smaller blood vessels branch off, some disappear, others join up to become the named arteries we know.
Okay, I'm picturing like two tubes merging and all these little side roads forming and rearranging. So what does overfusion mean here?
Well, the theory suggests this merging process just doesn't happen quite right. It might fuse too much or in the wrong way in that segment.
Ah.
And one piece of evidence supporting this is that doctors often find a lack of the usual paired lumbar arteries within that narrowed aortic segment. Often there's just a single lumbar artery trunk instead of the normal pair.
That's a very specific clue. It makes sense. If the main merging isn't right, it affects the smaller branches. Now, you also mentioned aortic hypoplasia, the generally smaller aorta. Is that a similar developmental hiccup?
It is related, yes, and also happens during development. With aortic hypoplasia, doctors often see multiple renal arteries going to the kidneys.
Multiple arteries to one kidney.
Yeah, sometimes. The thinking here is that because the main aorta isn't developing properly, it messes with the normal process where a fetus usually starts with several small arteries to the developing kidney. These are called metanephric arteries. Normally, most of these regress, leaving just one main renal artery per kidney. But if the aorta's development is off, maybe these extra arteries don't get the signal to disappear, and they stick around after birth.
So the main highway isn't built right, and the connecting roads stay disorganized.
Got it. Now, are there other factors besides these very early developmental events? I think our sources mentioned genetics.
Oh, absolutely. There are several genetic conditions linked to abdominal aortic coarctations. The one we see most often is neurofibromatosis type 1, or NF1.
NF1, right.
Others include Williams syndrome, Alagille syndrome, and tuberous sclerosis. The general idea is that these conditions might somehow interfere with normal cell growth or even cause cell death in the developing blood vessel tissues in utero.
NF1 comes up a lot in various health contexts.
Right.
What's the specific link to these vascular issues?
Well, NF1 has a wide range of effects, and the vascular system is definitely one. You can see things like aneurysms, abnormal artery vein connections, even heart valve issues.
But the most common vascular problem in NF1 is actually hypertension. high blood pressure, often caused by renal artery stenosis, narrowing of the kidney arteries, or, like we're discussing, narrowing of the abdominal aorta itself.
Okay.
But what's really interesting and kind of tricky is pinning down one single cause within NF1. It likely involves other modifying genes and also changes in how the gene for elastin, the key part of vessel walls, is actually used.
It's complex.
Very. The numbers are significant, though. Our sources say over 25% of patients with abdominal aortic coarctation or hypoplasia also have NF1. And looking the other way, about 13% of NF1 patients with vascular problems have these abdominal aortic coarctations.
That's a pretty strong link. So NF1 increases risk, but it's not the only potential cause apart from that early fusion issue.
Exactly. We also need to think about inflammatory and infectious factors. For instance, there's Takayasu arteritis.
Ah, yes, the inflammatory one.
Right. It's an inflammatory disease that can narrow the aorta. It usually hits the aortic arch in the chest more, but it can affect the abdominal aorta and needs to be differentiated from these abdominal narrowings. And in some parts of the world, like the Indian subcontinent, it might actually be a more common cause in kids.
Interesting regional difference.
Yeah. And then there's maternal rubella infection, German measles, during the first trimester.
Right.
That's been linked to the baby developing abdominal aortic hypoplasia, possibly because the virus damages the cells needed for normal vessel growth.
Wow, rubella really highlights the importance of maternal health. What about things after birth? Anything there?
Well, there's been some association noted with umbilical artery catheters in newborns, sometimes needed for sick or premature babies.
Mm-hmm.
But in those cases, the more frequent issues are actually blood clots in the aorta or maybe infected aneurysms, rather than this kind of developmental narrowing forming over time.
Okay, so it seems like a range of factors, but that early developmental issue with the dorsal aortas fusing seems like a primary driver for the coarctation itself. Now, what about the renal and splanchnic arteries? Kidneys and intestines, they often get involved too, don't they?
Oh, very frequently, yes.
Yeah.
The sources tell us that stenoses, or narrowings, of the splanchnic arteries supplying the gut, stomach, liver, are seen in about 87% of kids with abdominal aortic coarctation.
87%, that's high.
It is, and renal artery narrowings occur in about 62% of these cases. Interestingly, in children of North American Caucasian background, these narrowings are thought to be mainly developmental.
Whereas elsewhere.
In other regions, say Asia or Africa, inflammatory conditions might be a more frequent cause.
So it's likely the same underlying developmental quirks affecting the aorta are hitting these branches too.
That's the strong suspicion, yeah.
Yeah.
And again, many of these kids with both aortic and other artery narrowings also have NF1, reinforcing that shared developmental origin idea. The renal artery narrowings we typically see are right at the opening from the aorta, the ostium. And these aren't just slight kinks, it's often true underdevelopment, hypoplasia.
So the artery itself is just too small.
Exactly. Studies show they're significantly smaller. And under the microscope, the tissue is abnormal. There's this intimal fibroplasia, thickening of the inner layer, disruptions in the elastic lamina, a thin muscle layer, and too much elastin in the outer layer.
So the whole structure of the artery wall is just different. And the splanchnic arteries, the celiac to the stomach, liver, and the superior mesenteric to the small intestine.
Similar story there. We see similar ostial stenosis, narrowings right at the origin of the celiac artery, CA, and superior mesenteric artery, SMA, in children with aortic coarctations.
Okay.
The cause is thought to be tied to how these vessels develop in the embryo, involving things called ventral segmental vessels and the roots of the vitelline arteries. These embryonic structures form the CA and SMA, so early disruptions can have lasting effects. It's another example of that ripple effect from early development.
A developmental domino effect. Now, are these narrowings always a major problem right away, or can they worsen as a child grows?
That's a really critical point. Some might not be severe initially,
Okay.
but what can happen is, as a child grows, these narrowed segments might not grow proportionally with the rest of the vascular system.
Yeah.
So the healthy vessels enlarge, but these narrowed origins don't keep pace.
Ah, so they become relatively tighter.
Exactly. They can become critically stenosed, significantly blocked over time. It suggests maybe a kind of growth arrest right at the aortic origins of these arteries.
So something seemingly mild early on could become a big deal later, really emphasizes needing ongoing monitoring. Let's shift to how these issues actually present. What are the clinical signs, the symptoms doctors look for?
Well, the most significant sign, often, is renovascular hypertension, high blood pressure caused by kidney artery problems.
Right.
In fact, it's the third most common cause of pediatric hypertension overall, after kidney tissue problems and coarctation in the chest. And it accounts for a larger slice of the severe high blood pressure pie in kids, maybe 8 to 10% of marked elevations compared to adults.
That's surprisingly high for kids. And how does the aortic narrowing itself contribute to the high blood pressure?
Well, if the aorta narrows above or at the level of the renal arteries, it can directly cause hypertension,
Hmm,
like kinking a hose, right? Pressure builds up upstream.
makes sense.
But this can be made even worse by those renal artery narrowings we just talked about. And in those complex cases, the high blood pressure is often really tough to control with standard medications. It's not uncommon to see kids on 3, even 4 or more different antihypertensive drugs.
Wow, that sounds like really stubborn hypertension. Are there other symptoms besides blood pressure?
Yes, sometimes. Some kids might report leg fatigue with exercise due to the aortic narrowing, but it's not super common, and true claudication, that leg pain with exercise stopping at rest, is rare. Now, if the splanchnic arteries to the gut are significantly narrowed, which only happens symptomatically in about 6% of these kids, despite the high rate of stenosis.
Right. Only 6% are symptomatic.
Symptomatic, yeah.
Yeah.
They can develop issues with gut blood flow. Typically, it's postprandial intestinal angina, basically, a tummy ache, often around the belly button, after eating.
Ah, the food hurts scenario.
Exactly. It can get bad enough that kids develop a fear of eating cytophobia and they can lose weight because of it.
So, unexplained belly pain after meals in a child should definitely be a red flag here. And what about symptoms directly from the high blood pressure itself, the renovascular hypertension?
You know, most kids with renovascular hypertension actually don't have obvious symptoms.
Really? Asymptomatic?
Often, yes. But if symptoms do show up, they can be varied headaches, sometimes seizures, nosebleeds, even vision problems. One less common but notable sign is sudden facial weakness on one side, Bell's palsy, usually linked to very severe hypertension.
Those are serious potential signs. What about the longer-term consequences if these conditions aren't picked up and treated?
Well, chronic renovascular hypertension in kids can actually slow down kidney growth and eventually lead to chronic kidney problems.
Okay, so kidney damage.
Yeah. And more acutely, unrecognized, untreated severe hypertension can lead to hemorrhagic stroke, bleeding in the brain, or hypertensive encephalopathy, which affects brain function, development, cognitive ability, and even failure to thrive, where kids just don't grow properly.
Goodness.
And the heart takes a strain, too. Poorly controlled hypertension causes the left ventricle, the main pumping chamber, to thicken LVH, left ventricular hypertrophy. Over time, that can lead to heart failure. And in rare, severe cases, if basically all kidney blood flow is compromised, you can get flash pulmonary edema, sudden fluid in the lungs, along with kidney failure.
So the stakes are incredibly high. It's not just about blood pressure numbers, it's preventing these devastating complications. How do doctors actually diagnose this in children then? What's the process?
Usually the first step, if doctors suspect renin-mediated hypertension, kidney-related, is renal sonography, an ultrasound of the kidneys.
Ultrasound first?
Right. It can give clues about kidney size, blood flow in the kidneys, and the renal arteries. It's
Mhm.
moderately sensitive and specific, but accuracy really depends on getting a very detailed study.
And I imagine with imaging advances, there are more detailed options now.
Oh, absolutely.
Yeah.
We're increasingly using things like CTA, computed tomography, angiography,
Mm.
a CT scan with contrast dye for the vessels, and MRA, magnetic resonance angiography, which uses magnets, not radiation.
Right, CTA and MRA.
These are becoming more common as first-line tests. There's always concern about radiation with CT in kids, of course, but the newer low-dose CTA techniques have really helped minimize that risk while still giving good images.
And MRA avoids radiation altogether.
Exactly. And there are even advanced MRA techniques like time-resolved 3D sine phase contrast MRI that can actually visualize blood flow dynamics, which is incredibly useful before and after treatment.
That sounds like it gives a really functional picture. What about looking elsewhere? You mentioned NF1 links. Are other vessel issues common?
That's a good point. We've seen that a small percentage of kids with Middle Aortic Syndrome, maybe 3% to 13%, also have abnormalities in the blood vessels in their brain.
In the brain? Like what?
Things like narrowing or blockages of brain arteries, or even brain aneurysms.
Yeah.
Because of this possibility, doctors should really consider screening the brain's blood vessels, probably with contrast-enhanced CTA or MRA, in kids diagnosed with MAS.
A reminder, these can be systemic vascular issues. Okay, and what about the traditional angiogram, threading a catheter in? Still used?
Oh yes, catheter-based digital angiography is still extremely important. Doctors usually proceed to this if there's a strong suspicion of renovascular disease causing the hypertension.
So if other tests point that way.
Right. It remains the most valuable diagnostic study for getting the fine details. And it's absolutely essential for planning any kind of intervention, surgical or endovascular. It gives the most precise map.
Okay, so a stepwise approach. Ultrasound, maybe C-TAMRA, then angiography for the detailed plan. Let's talk management. Once diagnosed, what's the initial approach? Medical management.
Yes, the main goal medically is to get the child's blood pressure down to a healthy level, ideally below the 95th percentile for their age, sex, and height. Or even lower, maybe below the 90th percentile, if there's already evidence of heart strain, like LVH or other organ damage. Managing blood pressure in very young kids can be particularly tricky, needing close monitoring and frequent medication adjustments.
And are there specific pitfalls with blood pressure meds in these kids given the underlying vessel problems?
There definitely are some important nuances. ACE inhibitors and ARBs, those classes of drugs can be very potent and sometimes work when others haven't.
Right, the ACEs and ARBs?
But they can be risky if a child has narrowing in the arteries to both kidneys or in a solitary kidney that's affected, especially if kidney function is already borderline. You absolutely have to monitor their serum creatinine closely after starting them.
Check kidney function carefully. Got it. Anything else?
Well, clonidine is another one. Stopping it suddenly can cause rebound hypertension and tachycardia, a dangerous spike in pressure and heart rate.
Not good.
And it's sometimes given as a patch, especially in little kids. But if that patch falls off accidentally, you can get wild swings in blood pressure. Also, diuretics, the water pills, should generally only be used in combination with other meds here. Using them alone might actually worsen the hypertension by kicking up renin release.
So careful medication selection and monitoring is key. What happens when meds aren't enough or the narrowing itself needs fixing? That brings us to surgery, right?
Exactly. For isolated abdominal aortic coarctations, where it's just the aorta narrowed locally, the preferred surgical fix, if feasible, is usually a patch aortoplasty.
A patch to widen it?
Right. The surgeon sews a patch of material under the narrow bit to make it wider. But if the aorta is very narrow, or if the narrowing involves the renal and splanchnic artery origins in a really complex way, a more extensive operation called a thoracoabdominal bypass might be needed.
Bypass the whole segment.
Correct. And for the graft material, in both cases, expanded polytetrafluoroethylene, EPTFE, is generally favored now over older woven or knitted grafts. It tends to hold its shape better long term.
Makes sense. What about the timing? Age must be a huge factor with growing kids.
It's a massive factor. We know that operating on younger children carries a higher risk of needing repeat surgery later on.
Because they grow out of the repair.
Partly that, and also the technical challenges operating on tiny vessels, the risk of spasm, needing grafts that accommodate growth. So, for very young children, say 3 or 4 years old, doctors often prefer to manage them medically, if possible.
Buy some time.
Exactly. Plan for a definitive surgical repair when they're older, maybe 5 or 6 or older, when the vessels are larger and the long-term success rates tend to be better.
Let's talk more about those surgical techniques. Patch aortoplasty, when is that the go-to?
It's typically the best option when the narrowed aortic segment isn't too tight and still has enough diameter that the surgeon can sew the patch on without the stitches overlapping. It also has some blood flow advantages for the renal arteries compared to a bypass sometimes.
Okay.
The patches used in kids are carefully sized, big enough to allow for future aortic growth, but not so big they create sluggish flow that could cause clots. And often this is done at the same time as any needed repairs to the renal or splanchnic arteries.
And the thoracoabdominal bypass, when is that needed?
That's usually for more severe or longer narrowings that a patch can't fix, or when the disease is really complex involving the artery origins.
Okay.
Here, the surgeon uses a graft, a new tube, to go around the blockage. It usually starts on the aorta above the narrowing, maybe lower chest aorta or upper abdominal aorta runs down, often behind the left kidney, and connects to the aorta below the narrowing.
A major rerouting.
It is. And choosing the graft size is crucial. You oversize it a bit to allow for growth. Guidelines suggest maybe 8-12 millimeter diameter grafts in young kids, up to 14-20 millimeters in teens. After about age 9 or 10, the abdominal aorta doesn't grow much in length, so extreme oversizing isn't as critical then. Again, this is often combined with renal or splanchnic artery repairs.
These sound like big operations. What are the typical outcomes?
Generally, open surgery, patch or bypass, is very successful. It helps well over 90% of patients. Morbidity, complications right after is relatively low, maybe some bleeding or pancreatitis, inflammation of the pancreas. Mortality risks should be near zero in experienced centers.
That's encouraging.
But long-term follow-up is crucial. Checking arm and ankle blood pressures, the ABI, is important. If that index drops, it might signal stenosis, narrowing at the repair site, prompting more imaging, usually MRA.
And reoperations.
They can be needed, yes, either for narrowing at an anastomosis, a connection point, or just because the child outgrew the initial repair. One large center reported about a 10% reoperation rate, happening 5 to 12 years later.
Okay, so reoperation is possible, but initial success is high. You mentioned a retro-aortic tissue expander earlier. Sounds different.
It's a more novel technique, yeah. The idea is to encourage the healthy aorta below the coarctation to grow longer on its own.
How?
A special inflatable device is placed behind the aorta. Over months, it's gradually inflated with fluid via a port under the skin. This gentle, controlled expansion stretches the normal aorta, stimulating longitudinal growth.
Wow.
Once it's long enough, the narrowed coarctation segment can be cut out, and the now longer healthy ends can be sewn directly together. Its long-term value is still being studied, though.
Really interesting idea using the body's growth potential. Now, what about the renal arteries themselves? How are they fixed surgically?
Well, the goals are to minimize kidney ischemia, lack of blood flow during surgery, and restore durable flow. It's technically tricky in infants with tiny arteries, so while emergency surgery is sometimes needed for critical hypertension or kidney failure, elective repairs are generally more successful after age 3 or so. The specific technique depends on the lesion. Renal artery reimplantation is common, disconnecting the healthy artery beyond an ostial narrowing and sewing it back onto the aorta or a nearby healthy renal artery.
Moving the connection point.
Exactly. If that's not possible, maybe the narrowing is longer or involves branches, then a bypass graft is used. The internal iliac artery from the pelvis is a good graft source. Vein grafts aren't recommended anymore in kids due to aneurysm risk later.
Right, use an artery graft.
Yeah. Less common options are resection and reanastomosis, patch arterioplasty, or open dilation during surgery. Using the splenic or hepatic arteries for bypass isn't favored because of the frequent splanchnic narrowings in these kids.
And sometimes is removing a kidney nephrectomy necessary?
Unfortunately, yes, sometimes. If the renovascular disease is unreconstructible, maybe multiple severe narrowings deep inside the kidney, or if a kidney is tiny and non-functional and the other kidney is healthy, nephrectomy might be the best option. And for segmental renovascular hypertension, where just one part of the kidney is causing trouble, a partial nephrectomy might be possible to preserve some function.
So a very tailored surgical approach. You mentioned large studies on outcomes. What do they generally show for the renal artery repairs?
Several major centers have reported their experiences. A fairly recent University of Michigan series on 169 kids showed open surgery cured hypertension in 44% and improved it in another 45%. Reoperation rate was 21% over many years, with no surgical deaths.
Cure or improvement in almost 90%.
Pretty good, yeah. Other large series from France, Cleveland Clinic, Vanderbilt, Philadelphia show fairly consistent results for renal artery repair, specifically hypertension cure rates often in the 66–70% range, improvement in the mid-20s, and low failure rates. There are also reports on complex bench repairs, taking a kidney out, fixing it, putting it back, showing good results for tricky segmental disease in smaller series.
So overall, surgery seems quite effective for pediatric renovascular hypertension. What about the splanchnic arteries, the gut supply? When is surgery done there?
Mainly when those CA or SMA narrowings are actually causing symptoms like that postprandial pain.
The intestinal angina.
Right. Prophylactic repair might be considered if an aortic or renal surgery could make future mesenteric access difficult. But otherwise, it's usually done only if symptomatic. Internal iliac artery grafts can be used for long narrowings or direct reimplantation to the aorta for osteal lesions.
And does it help the symptoms?
Yes, symptomatic patients usually gain weight and get relief from the pain. Importantly, endovascular approaches like balloons or stents are generally not considered appropriate for these developmental splanchnic lesions in kids.
Okay.
We don't fully know the natural history if they're left untreated, so long-term follow-up is recommended. And it's crucial patients know about collateral flow, often via the inferior mesenteric artery, especially if they need other abdominal surgery later. Disrupting that backup supply could be catastrophic.
Good point about collateral circulation. Okay, so open surgery clearly has a major role. What about endovascular treatment, the catheter-based, less invasive stuff? Does that work here?
For the abdominal aorta narrowings, endovascular treatment, like balloon angioplasty or stenting, can sometimes reduce the pressure gradient initially.
Okay, some short-term benefit.
Potentially.
Yeah.
But compared to open surgery, it comes with higher perioperative morbidity complication rates, around 30% reported in some series. Things like renal artery injury, aneurysm formation, stent migration.
Oof, 30% is high.
It is. And there are higher rates of stenosis, the narrowing coming back, needing reintervention. Freedom from reintervention might be only 55% at 1 year, maybe 33% at 5 years in some studies.
Not great long-term durability.
Not compared to surgery. For select, very focal coarctations away from major branches, maybe, especially if it's arteritis related. But developmental narrowings tend to recoil after ballooning, often needing a stent.
Right, they spring back.
Exactly. And the long-term benefit isn't proven, plus failed endovascular treatment makes subsequent open surgery much harder.
Okay, so caution advised for aortic endo in kids. What about for the renal artery stenosis specifically? Endo works well in adults sometimes, like with FMD. Does that apply here?
Well, endoluminal intervention has been beneficial in young adults, especially with FMD, and it is being used more in kids. Some initial reports look promising,
Right.
but larger experiences show lower cure rates for hypertension compared to open surgery. Maybe cure rates in the low 20s, improvement in 40%, but failure at over a third in one series. Similar failure rates, 24–44% in others.
Why the low success?
It might be the nature of these developmental lesions, that intimal fibrosis, the elastic recoil, just tough tissue. Plus, there's a risk of thrombosis, clotting in these small arteries from the angioplasty forces.
Mm.
So while you might consider endo as a bridge to surgery as a child grows, you have to weigh the risk of irreversible complications. The role remains pretty controversial.
And if endo fails for the renal artery, how does later surgery go?
Unfortunately, remedial operations after failed endovascular therapy are more complex and generally less successful than primary open surgery. Lower cure and improvement rates for hypertension.
So starting with endo might compromise the best surgical outcome later.
That's the concern. Patient selection for endo needs to be very careful, considering the small vessel size and the fibrotic nature. Stents should generally be avoided in kids if possible. They cause neo-intimal hyperplasia, stenosis, and obviously don't grow. Any pediatric endovascular therapy really needs to happen at high-volume centers with very experienced teams.
Okay, so while endovascular techniques are advancing, it sounds like open surgery remains absolutely critical, maybe even the primary approach for many of these developmental aortic, renal, and splanchnic issues in children.
Absolutely. Managing these complex kids really requires a multidisciplinary team effort. You need vascular surgery, nephrology, radiology, cardiology, all working together.
Collaboration is key.
It is. A disease-specific, patient, and family-centered focus is just essential for optimal care.
This has been a really illuminating deep dive into a complex, but wow, incredibly important area of pediatric health. So just to recap, we've explored the complexities of these developmental disorders affecting the aorta and its major branches in kids. We've seen how tricky understanding their origins can be, but also the remarkable progress in treatment.
Yeah.
Early, accurate diagnosis and tailored treatment strategies are paramount. And while less invasive endovascular options are evolving, open surgical management clearly remains a cornerstone, often the preferred approach for many of these young patients.
Indeed. And it's so important to remember that while we've learned a lot, there are still critical research questions. I mean, given the developmental origins and the potential for lifelong impact, what are the key things we still need to figure out? A deeper grasp of the precise genetic and embryologic triggers could, potentially lead to even earlier detection, maybe even less invasive or preventative strategies down the road. That's the hope, right?
A really important thought to end on: where does the research need to go next? Thank you so much for sharing your expertise and guiding us through this complex topic today.